The primary utility of bedside ultrasound of the IVC is to aid in the assessment of intravascular volume status of the patient. This may be a particular utility in cases of undifferentiated hypotension or other scenarios of abnormal volume states such as sepsis, dehydration, hemorrhage, or heart failure.
Fasting before the exam is recommended whenever possible. This will aid in decreasing the amount of bowel gas shadows, which can drastically decrease the quality of images. To obtain a transverse view of the IVC, place the probe on the midline, halfway between the xiphoid process and the umbilicus. The probe marker should be pointing toward the patient's right side. Adjust the gain and depth to obtain the best possible image. In this transverse view at the level of the mid-abdomen, both the IVC and abdominal aorta are seen just anterior to the vertebral body. There are several features that will help to distinguish the abdominal aorta from the inferior vena cava. The aorta tends to be located to the left of the patient's midline, whereas the IVC is located to the right. The aorta appears circular in cross-section, while the IVC may appear elliptical or teardrop-shaped. The aorta is pulsatile, while the IVC is not as pulsatile. The aorta is not compressible under gentle pressure, but the IVC is. The abdominal aorta shows no change in size with respiration or sniffing, whereas the normal IVC shows up to 50% or more change in diameter with respiration or sniffing.
There are two approaches to perform IVC ultrasound. The first is to obtain a subxiphoid view of the heart by placing the probe on the patient's abdomen just below the xiphoid process with a probe marker towards the patient's right or at 9 o'clock. Once an appropriate subxiphoid view of the heart is obtained, the probe is rotated 90 degrees until the marker is pointing towards the patient's head. At this point, the IVC should be visualized in a longitudinal plane.
The inferior vena cava. To obtain the IVC view, begin with the subcostal view and narrow in on the right atrium. Turn the probe counterclockwise until the dot is facing the patient's head. Slightly tilt the probe to the patient's right to bring the IVC into view. Note the IVC runs through the liver. The structures are labeled.
A phased array transducer with a cardiac exam type is used to perform an inferior vena cava ultrasound exam. The inferior vena cava is evaluated at the level of the liver and diaphragm. The transducer is placed to the right of the epigastric midline with the orientation marker to the patient's feet. As an alternative approach, this exam may be performed using an abdomen exam type with the orientation marker to the patient's head. The liver, diaphragm, right atrium, and inferior vena cava are identified in this view. Sweep from side to side to differentiate the inferior vena cava from the aorta. The aorta is thicker-walled and pulsatile. The superior mesenteric and celiac branches of the aorta are identified at this level. The inferior vena cava is thin-walled and changes caliber with respiration. The diameter of the inferior vena cava decreases with inspiration and increases with expiration.
Just to the right of midline at the costal margin, and identifying the internal landmark being the liver as the acoustic window to the IVC. You see the IVC running deep to the liver there. Make sure you identify the junction of the IVC at the right atrium, and equally as important, the middle hepatic vein should also be identified to ensure that you are in fact looking at the IVC and not the aorta. The IVC can be mistakenly foreshortened in the long axis to give it the impression of being a flat IVC in what's called the cylinder effect. And this happens when you're not in the true center of the vessel, but have brought the scanner off to one edge or the other edge of a longitudinal.
So understand the concept of IVC. So when you breathe in, imagine the pleural pressure would go down. And then, of course, the IVC would drain nicely into the RA. And of course, when it's draining in very easily, the IVC diameters would collapse. So basically, when you inspire, the diameter should change more than half, or 50%. This is called the collapsibility index, 50%. So what if the patient is intubation or have mechanical ventilation? What happens is that when you put a tube in the patient, you blow up the patient lung in the inspiration phase, and it increases the pleural pressure. So what happened? The IVC cannot drain in the RAA anymore. Also, it would result in the distance of the IVC in the inspiration phase. So if the variation or the distance of IVC is more than 18%, it means that your patient would probably is volume responsive. The spontaneous breathing and intubation patient has different only in the inspiration phase. So basically in volume responder, if the patient is spontaneous breathing, the patient would have collapsed IVC and small IVC, while if the patient is intubated, contrast to collapsed IVC, they would have, this 10 IVC in state. But to easily remember is that if the IVC is vary, then it means the patient is volume responder. You should give them fluid.
Another important concept, apart from the absolute diameter of the IVC, is measuring the collapsibility of the IVC. In state of low intravascular volume, the percentage of collapse is higher when compared to the state of intravascular volume overload. This is quantified by the calculation of the Cava index, where the IVC diameter during expiration is measured, where you subtract the maximum diameter of the vessel with the minimum diameter of the vessel and divide it by the maximum diameter of the vessel. The Cava index is a percentage, and where the number is close to 100 is indicative of almost complete collapse and therefore volume depletion, while a number close to 0 suggests minimal collapse and likely volume overload. When measuring the diameter of the IVC, it's important because you want to use this diameter to calculate the Cava index. The IVC should be measured 2 centimeters from where it enters the right atrium. And this is another still image that shows how to measure the IVC. They take about 2 centimeters from the entrance into the right atrium and measure the diameter of the IVC, with the beam overlying the IVC 2 centimeters from the right atrium junction. The inspiratory and expiratory diameter can then be measured on the M-mode image at the smallest and the largest location. This is an example of an M-mode image. You'll see on the left side, you'll see almost completely collapsible IVC with a Cava index calculated at 60%, while on the right side, the Cava index is close to 0, indicating minimally collapsible IVC. Frankly speaking, you don't even need to measure and have these numbers. Just visually looking at the IVC and the M-mode graph, you can definitely see that the IVC is collapsible on the left compared to the right.
So of course, this is an easy 2Ds. The first one, as you can see here, the IVC, the check mark or the Nike logo here, is very thin. When you breathe in, of course, there's no space at all. It means this patient should be volume responsive when he or she come in with shock or dyspnea. However, in another patient on the right of the screen, as you can see here, the IVC is very, very big. It doesn't collapse at all, whether inspire or expire. So basically, this should be the patient with high CVP, or maybe it doesn't respond to volume anymore.
This table indicates the approximate CVP based upon the IVC collapsibility index.
And I'm going to be demonstrating the proper technique to visualize the inferior vena cava.
All right, so what Danny's doing here is he's just taking a curvilinear 3 to 5 megahertz probe. He's aiming the indicator towards the head. He's placing it just under the xiphoid process, and then he's just sliding 1 to 2 centimeters to the patient's right. So that's the deal. Probe goes just under the xiphoid, slide 1 to 2 centimeters to the patient's right, and this IVC is collapsing nearly completely. But anything greater than 50% is a patient who's going to be responsive to fluid. So that's been the most validated number. If the IVC collapses more than 50%, give them some fluid. I would tell you if it's greater than 30%, which is really what you could easily see with your eye, I would probably, in most cases, give them fluid. So if you're really seeing any significant collapse, then the patient needs fluid. All right, we gave that patient 4 liters of fluid. Look at the IVC now. No respiratory collapse. If we look just past the hepatic vein, that IVC is not collapsing with respiration. It's staying pretty much identically sized throughout the respiration cycle. This patient doesn't need fluid. All right, another patient who has near complete or certainly greater than 50% collapse of their IVC with respiration. Patient needs fluid. All right, we gave that patient 2 liters. We take a look at the IVC again. It's bigger, but it's still collapsing greater than 50%. More fluid needed. Here's another patient that needs fluid. IVC collapsing just past that hepatic vein with respiration. All right, we gave that patient 6 liters of fluid. Look at the IVC now. No respiratory collapse.
Some important pitfalls to mention. Plethoric IVC is not always from volume overload. Remember, there are other causes for distended IVC, including tension pneumothorax, massive pulmonary embolism, pericardial tamponade, and mitral regurgitation or aortic stenosis. So, in summary, IVC evaluation for volume status assessment is easy, non-invasive, reproducible, and fast. A meta-analysis of 5 studies concluded that a moderate level of evidence suggests that the IVC diameter is consistently low in hypovolemic status when compared to euvolemic status. This table is from one of the studies included in this meta-analysis. The study was done in an ICU setting with 23 ventilated patients who were septic. Measurements were performed at baseline and after volume expansion. Patients were separated into responders when the caval index was greater than 15 and non-responders when the caval index was less than 15. The results of the study showed that using a threshold of the distensibility index of the IVC of 18%, responders and non-responders were discriminated with 90% sensitivity and 90% specificity. And a strong correlation was observed between the distensibility of the IVC diameter at baseline and the caval index increase following blood volume expansion. So baseline central venous pressure did not accurately predict volume responsiveness. So this is another study that goes against using the CVP. And the conclusion from this study is that they suggest using respiratory changes in IVC is accurate measure of predicting fluid responsiveness in septic patients.